everyone, so we'll go ahead and get started on chapter 28. This is our soft tissue injuries. I've divided this into two sections. The first section will talk about like obvious gross soft tissue injuries, and the second section, which is within this chapter, talks about burns. And so the burns will be the next video because that burns are super important. They get tested a lot. So anyways, here we go. So you should know that the skin is the body's first line of defense. What's the other word for the skin? It's the integumentary system. And so this protects you not only from like viruses and bacterias and funguses, but it protects you from, the environment. So, other people and blunt trauma and the heat and the cold and the rain. And so it has a lot of different roles. So I think that sometimes we take that for granted and overlook that, but it is the first line of defense in almost anything. But of course, the skin is not invincible, and so it can be injured, and so we face a lot of lacerations and abrasions and avulsions or whatever injury burns, and so that's what this chapter talks about. And so soft tissue injuries may result in exposure of deep structures. And so the interesting thing about like soft tissue injuries is they're gruesome. And so this tends to rattle people. And when you see someone who's eviscerated or someone who has a very deep laceration to the arm or especially the face, it's very scary because you've probably never seen that before in real life. And so, this can be overwhelming for some people, but dressing and bandages are applied to, we'll use this to control bleeding and prevent further contamination, like from mainly bacteria, and to prevent the wound from further damage from the environment, i.e. through heat loss or blood loss, or through further like tissue damage, like tearing and ripping. Okay. And so there's different categories, and like I said, the first part of the first video that we're doing now will cover blunt and penetrating injuries, and the last video will cover burns. And so I think that we, as EMTs and paramedics, do a good job recognizing that hemorrhage is a frequent cause of death from soft tissue injury, right? So if I were to slice your wrist open, it's a soft tissue injury, more so a vessel injury, and you're going to bleed to death if you don't fix it. But the risk of infection is something that we often don't pay real close attention to in EMS. Thankfully, due to very powerful and effective use of antibiotics, you don't have to. I mean, that's not particularly lethal anymore, but it is still a consideration. So this is why we should clean and irrigate wounds and try to keep them clean as possible. Okay. And so what I'm getting at with that is sometimes we tend to forget about the whole keep it clean thing. That would be the goal. And then protective actions are important to prevent soft tissue injuries. Sure. Now there's let me just show you this slide. There's three parts of the skin that you want to know, but the actual skin itself, is the epidermis and the dermis. And so remember, the word epi means outer, and so the epidermis, these are dead cells, right? And so the epidermis is not, it's not technically living cells anymore. And so this is the outermost layer of the skin. Like if you look at my skin, what you're seeing is the epidermis. Okay, and so what happens is you have this membrane right here that divides the epidermis and the dermis. And so the dermis is this thicker layer. And so this is where a lot of the structures of the skin, like nerves and sebaceous glands and hair follicles and capillaries, all of these things are up underneath in the skin, embedded within the dermis layer. And so this is an important thing to know when we talk about like burns and like regeneration. And so this is not being pedantic, that everything on here you should know what it is and what it does, and a lot of it's intuitive. So to achieve that, I'll just work my way from the bottom up. First, I'll talk about the subcutaneous tissue. So subcutaneous means below the cutaneous level. And so the subcutaneous level is right here. And so these little fat, the fat actually does look like this if you ever cut someone open or see this. They're little beads. And so those are individual cells that are engorged with fat. And so when you start seeing fat, you're in the subcutaneous space. You're no longer in the dermis. The dermis doesn't have fat. It's really when you start seeing fat, you're past that. Okay. Now this is blown up to a very large scale, and so it's important to realize that the thinnest skin on your body is your eyelids, right? And the thickest skin on your body is going to be your palms and soles. And so skin has different thicknesses, but in general, if you were to like slice your wrist right here, right, that's fairly thin skin. And so This, I mean, this is going to be a millimeter or so, millimeter or two. The whole epidermis dermis structure, a couple millimeters, maybe 2-3 millimeters at the most on your arm. And so that's something I want to point out, that this is fairly thin structure. So just keep that in mind. Okay. And then, so let's just start at the bottom. So the bottom layer, we have the muscle. So this could be the muscle of your forearm or of your arm or wherever. And then there's this stuff called fascia. Notice how it's spelled weird. And so the word fascia, this is like connective tissue. If you've ever barbecued like a brisket or ribs or something, you've had to, what they call, I think they call it silver skin or something like that. You've had to rip off fascia because it's very fibrous, and it doesn't make good eating because it's so fibrous. And so this is the fiber that surrounds muscles that keep them in layers. And so that's called fascia. Okay. We'll talk about what a fasciotomy is later in burns. And so above that, we have subcutaneous fat. That's what these little beads are. It really does look like that. And then down here, we have some arterioles and veins that are branching off into arterioles and venules that will eventually branch off into capillaries. Okay. This is a hair follicle. And so down here, this is the follicle itself. We have something called there's sebaceous gland. Yeah, sebaceous glands here. The sebaceous glands up here, and it'll provide like an oily substance to enrich the hair follicle and keep it like more or less oily and lubricated. If you don't know, this is the cause of acne, right? These pores will get clogged, and then this will become infected through a bacteria that has the word acne in its name, and so this is why people get acne. And so this is a hair follicle. Hair follicles are everywhere in the body except the areola, which is the nipple, and the palms and soles. So keep that in mind. Now, moving forward, there's a muscle here called the rector pili muscle. So if you've ever had goosebumps, I'm sure you have. This is the muscle responsible for that. It pulls on the hair follicle to erect it and make it stand up straight. Okay. Over here, we have a nerve. So nerves are embedded into the dermis. This is an important concept when we talk about third-degree burns, because in a third-degree burn, when this gets burned, you no longer have sensation in third-degree burns. And so that's one of the important hallmarks when we try to diagnose burns, is if there's sensation in that area, it's not a third-degree burn. And so let's see, what else did I leave out? Oh, sweat gland. This is basically the idea is to release fluid up through a pore on your skin, that by evaporation and convection, it will cool you. And so that's the idea of that. Okay. I think I hit all of that, so we'll keep going. Now, there's these things called skin tension lines, and this is intuitive. So skin is in layers that provides tension. Okay. And so you could almost imagine that if I were to cut you from here to here, like center line in the abdomen, the skin will kind of pull. And so these are called lines of Langerhans. What these lines are showing you where the tension of the skin is. So you can imagine, based on how you get cut, is how far open that wound is going to get yanked open. Okay, it's kind of odd that they want you to know that, but so I don't have much more to add on that. Now, this is a bruise. We're going to talk about what the medical word for bruises are on the next slide, but a contusion is one of the medical words for a bruise. In fact, it's the exact translation. Contusion is a bruise. And so this is bleeding up underneath the skin. And so we should know that, if I were to punch you in the arm, that it's not going to immediately bruise, but it is going to immediately get red and inflamed and swollen, right? Rubor, tumor, dolor, right? All the hallmarks of inflammation. And so that's normal. And so what that is that's increased blood up underneath the skin, and that's why it's red and hot, because blood is red and hot. And so what happens as time goes on, blood breaks down into its two main components, heme and globin. Okay, hemoglobin. And so if you've ever wondered why a bruise starts out, really red, then it becomes deoxygenated, it turns purple, and then it'll turn like a greenish yellow color, and then it goes away. That's because the heme is breaking down. And so I say this all the time in my videos, but if you wonder why your urine is yellow, it is because that is heme. You have urobilinogen that has been broken down into its last stage into urobilinogen that makes your pee yellow. And so the same thing's happening with your skin, because what you're peeing out, that yellow stuff, is the byproducts of blood being broke down in the spleen and picked up in the liver and thrown to the kidneys and urinate it out. And so this is why bruises change color over time. And so we can use this occasionally, in forensics to be like, oh, well, these are not bruises that happened this morning, right? Like these, or just now, like these are not fresh bruises because they're already changing colors. And so you can use that sometimes in forensics and clinically to be like, ooh, this is an old bruise. And so I'll give you a better example when we use this is in child abuse. And so if you see, or even any type of abuse, if you see multiple bruises across the entire body in different stages of healing, so different colors, different sizes, different severity, then that is very indicative of abuse. Okay. Now, that's a contusion. That is the medical word for a bruise. Now, the word ecchymosis is this. This is the actual discoloration. And so where you see the word ecchymosis is where I most commonly see this tested is what's called periorbital ecchymosis. And so periorbital literally means around the orbit, around the eye, and it's bluish black in color. And so you see this with a black eye. It's called periorbital ecchymosis. And so that's where that word will come from. So if, again, when you see ecchymosis, contusion, hematoma, you need to think they're describing a bruise, okay? Now, the actual mass of blood up underneath the skin is called a hematoma. And I recently found out it's the same word in Spanish. And so it's the word hemato means blood. And then oma means mass. And so it's a mass of blood, but it's underneath the skin. Okay. And so this is a pooling of blood up underneath the skin. Okay. And then a crush injury occurs when substantial forces in the body is applied. So you can imagine what crushing is. We're going to talk more about that. So this is a bruise. You would imagine that this person, male or female, I can't tell, fell and they hit their eye right here on the curve of the orbit. And so they hit that, and so older people have more frail skin and especially more frail vessels. And so a vessel has ruptured up underneath the skin and caused that pattern of bleeding. And so this is a hematoma, okay? A contusion, and the color is described as ecchymosis, okay? So if I want to get real fancy, I could describe this as the patient has, that looks like a, I don't know, 10 by 8 centimeter hematoma just superior to the left orbit brim that has active bleeding noted on the left maxilla. This is the maxilla right here, right? So like this is where those words kind of become important when you read that on a vignette, or if someone's telling you this, or if you're reading this in a question, or if you're reporting this to the ER doctor, et cetera, et cetera. So that's where these whole medical terms come into play. Now, I have a test question coming up on this on exam 2, if you're paying attention. I've created your exam 2. It talks about crush syndrome, okay? And so what happens is, in crush syndrome is, I'll just read this. Tissue necrosis develops and results in release of harmful products into the bloodstream when the limb is freed from entrapment, okay? And so what happens in crush syndrome is, let's just imagine a big boulder is laying on top of my arm, like a 5,000-pound rock, and it's squished my arm, okay? And I'm trapped for hours, okay? All the cells in my arm are going to start dying and exploding, okay? And so as they explode, they release their products, namely potassium and lactic acid. And so what happens is when I'm freed, you have to worry, when that boulder is lifted off my arm and blood starts coming back through towards my heart, you have to worry about all that nasty stuff that built up in your arm going to your heart and your body, your brain, mainly your heart, all at once. And so that's the issue with crush syndrome that you have to worry about. But mainly too, the tissue necrosis. The tissue will necrose, so it will die from being trapped, from being crushed, okay? So this could be a boulder that seems to be a crowd favorite in exam questions, or it could be a car, or, an entrapment inside a vehicle. The dash is rolled onto your legs and have crushed them. There's all sorts of scenarios this could happen, but think crush, something very big, something very heavy has crushed you. Now, it's a little different from, students confuse the two, compartment syndrome. So your muscles, especially your extremities, this happens in extremities, so watch out for this in extremities. Your extremities have compartments. Each muscle has its layer of fascia. Remember, fascia is the silver skin on ribs and brisket that is very fibrous. And so it's wrapped around the muscle. And so when you have swelling of the muscle, for whatever reason, trauma, burns, infection, any type of swelling of these compartments, they can get so swollen that you can cut off blood supply and nutrient to that muscle. So again, the muscle will die. It's almost like a crush syndrome. The tissue will become necrotic and you have to worry about it dying. And so how this classically presents, you have to watch for this in vignettes and in real life, is it'll be pain out of proportion with the injury. And so this is the patient that, they broke their arm, right, which is very painful, but it is extremely painful and they are just dying of pain, and you cannot control their pain with all the IV medication, right? And so that would be a classic scenario. Now, I'll give you an example that I encountered last week in the emergency room. We had a patient who we were consulted for general surgery who had huge ecchymosis down his leg. And so when we grabbed his leg, it was hot, and he actually had subcutaneous emphysema, which is when you push on the skin, there's air up underneath the skin. It feels like Rice Krispies. And so this is usually caused by a bacteria that will cause this necrosis. It's very fatal. I'll tell you, died the next day before we could even do surgery. And so what happens is the surgeon went in there and he started moving the guy's leg around. And he was like, oh, no, it doesn't hurt. That doesn't hurt. And the surgeon immediately said, well, okay, well, this isn't compartment syndrome yet. We'll monitor it. We'll come check on him tomorrow morning. And so the next morning we checked on him. It did hurt. We scheduled him for surgery for the next day, and he died. He was too unstable for surgery at the time. It's a long story. But what I'm getting at is that is compartment syndrome. The hallmark of that is you will move someone's extremity just passively. You're just passively moving someone's arm, and it is astronomically painful. Compartment syndrome. Okay? So do know the difference between those two. Now, again, with an open injury, you have to worry about the contamination, right? The presence of infectious organisms or foreign bodies, whether that is, asphalt from a road or dirt or cow shit or, whatever the scenario is. But you also have to keep in mind there's flora on our skin every day, right? Staph epidermidis, Staph aureus, right? Maybe, hopefully not Pseudomonas, but there's candidiasis or candida. That's a fungus. They're all just sitting on our skin, and that's normal. Okay. And so, of course, when you break this barrier, the first barrier of defense against infection, the skin, then you increase the risk of infection greatly. So our goal is to keep this clean and keep it covered. And so what they're showing you here is an abrasion. And so an abrasion is where you kind of scrape off the top layer of the skin. And so we've all had these. This is like a scraping, and they're showing you that here, like you scrape this off. Now, I will say something to know is you can see this in large proportions on what we call road rash, where like imagine someone's on a motorcycle without a shirt on and they fall off their motorcycle at 50 miles an hour and slide across the road. Their skin's gonna get slid off, and so it's gonna burn. So it's interestingly, this is treated the same as a burn because this is almost. I mean, it's identical. The treatment is identical to a burn. So just keep that in mind. Now, these are lacerations. It looks like someone got their leg stuck into maybe like a chainsaw or some type of machinery or equipment, like a lawnmower, I don't know. But this is obviously really bad. And so the word laceration is the medical word for a cut. And so they can be both smooth or jagged cuts caused by a sharp object or a blunt force that tears tissue. So to clarify, you could be lacerated by a scalpel or a knife or a chainsaw or a steak knife or whatever. But you could also be hit so hard with something you can lacerate the skin. So be aware, it can be a sharp object, but you can imagine, I mean, if you really swing a golf club as hard as it will go, right, you could lacerate someone's skin. That makes sense, and that's still blunt. So just keep that in mind. Now, this is an avulsion. Avulsion is different than abrasion. Students confuse the two. So let's talk about what an avulsion is. Avulsion is when you flap the skin. Okay, and so an avulsion separates various layers of soft tissue so that they hang as a flap. The key word here is flap. They flap open. Okay, and so this is what they're showing you an avulsion is. So you've kind of like opened it up. You flapped it open. You can flap it back. Okay, and this is very common in injuries, especially like car wrecks and stuff. People get avulsed all the time. Okay, and so amputation is completely avulsed body parts. So you could have a arm amputation, finger amputation, leg amputation, toe amputation, right? That's the completely removing of it. And of course, you'll see that. And the close relative of this is a partial amputation, where it's almost completely removed, but it's not completely removed. So be aware that when you call amputation, that means that it's a complete amputation. It has completely been removed. And if you want to say it's almost been completely removed, then that's called a partial amputation. Okay? Now, animal bites, consider all bites as contaminated and potentially infectious infected wounds. I can tell you human bites are usually worse than animal bites because of the bacteria that lives in nasty humans' mouths. One. Two, you have to worry about like infection with animals more so in the name of viruses like rabies. And so rabies is obviously very, very deadly, very rare in the United States. Rabies is most commonly carried by bats, not dogs or raccoons as you would think, but it's bats. And so just keep that in mind. Human bites need to be transported to the ER for several reasons. The first one is or any type of bite. Uh, Let me start over. All bites should be transported to the ER. Okay. You should gather information on scene. Whose dog was it? What type of dog is it? Because a lot of times a report has to be made, and the dog will have to be tested for rabies, or the animal, whether it's a skunk or raccoon, they'll trap it and test it for rabies, usually. And so the idea is these patients will almost always need antibiotics. This is not like, oh, it's just a little bite. You almost always need antibiotics for this, okay? Because you risk infection, okay? Same thing with I'll add same thing with cats, like a cat bite or especially a cat scratch. Cat scratch fever is a real thing, okay? So just be aware of that you have to worry about infection from cats and dogs and all of them. Now, a human bite has penetrated the skin should be regarded as a serious injury. Now, again, I'm telling you, humans have really nasty mouths. So be careful about human bites. They need to be transported. Okay? It's obviously assault to bite someone, too. It's a crime. So, now, this is a penetrating injury. So remember, anytime that something penetrates the skin, like it goes through the skin, like in this case, they show you this piece of wood, or in this case, it's a nail. But technically, a stab wound is if it pokes in, that's still considered a penetrating injury. Okay, when you poke someone. Now, if you slice someone, that's a laceration. It's different. So just keep that in mind. So this depends if someone's stabbing in this motion, right? Stabbing, or if they're slicing. It changes the injury patterns. Okay. And the reason that's important is how deep that goes, right? So how big was the knife? How deep did it go? Did they bury it to the hub? Versus if you just slice someone, that's usually a little bit more superficial. But when you start stabbing someone, it's a little different. Now, this right here is called an evisceration, okay? And so this is when the abdominal contents spill outside of the abdominal cavity. These are loops of small bowel. Right here is probably a loop of the colon or the bowel, I can't tell. But this is definitely small bowel right here. And so this is obviously very bad when this happens. And so the small bowel or abdominal contents even, when it protrude from the abdominal cavity, that's called an evisceration, okay? An open neck wound can be life-threatening. These are very difficult to treat. What are you going to do? Apply a tourniquet or direct pressure? So you usually have to use an occlusive dressing. These are very difficult to treat. So just keep that in mind. This one's. I'm sure this guy's dead. This is so deep. You can see how deep this is. It's way deep. His trachea is like right here. So he cut his trachea for sure. I'm sure he's dead with the way they have him draped. But anyways, just keep that in mind. Now, this leg looks like it got wrapped up into some equipment, like industrial equipment, because it's all torqued up and stretched out, and it's got a big hole in it, so that's bad. But anyways, open crushing injuries may involve damaged internal organs or broken bones. Blast injuries may result in multiple penetrating injuries. So, if there's ball bearings piped into a pressure cooker bomb, and you get hit with that, there's going to be multiple penetrating injuries. So that's intuitive. So again, infection becomes an issue. So the deeper the wound, the larger the wound, the location of the wound increases the risk of infection. The location of the wound. So if you have a large wound next to the anus, right, much higher risk of infection when there's poop going through there versus maybe on the chest, probably less likely to get infected. Now, Staphylococcus and Streptococcus, there's different types of these that live on the skin or in the environment. These are the most common causes of bacterial infections caused by an open wound. And so you would want to look for the obvious signs of infection. And so the obvious signs of infection would be like pus drainage, swelling, pain, fever, edema. Those are the things that you would look for. Loss of function. Now, this is an example of two examples of gangrene. And so gangrene means the mummification of tissue. And so it's dead tissue. And there's two types of gangrene. There's wet gangrene and dry gangrene. And this looks like a dry gangrene right here. And so it's dry. This tissue is completely dead. Okay, you will. I've seen this, and so this is completely dead tissue. It's almost like a greenish black color in real life, and it can be rather foul smelling. But when it's dry, it really doesn't stink too bad. And so this is obviously an issue, and you would ask yourself, oh my God, who gets this? Well, frostbite can lead to this, so extreme cold. The other way you can get this is from peripheral vascular disease, right? So if your arteries are all clogged up with Taco Bell in it, you have to worry about the arteries not reaching down here, and so you'll have decreased blood flow. So I will go a step further. Who gets decreased blood flow to the extremities? It's a type of endocrine disorder, very common. They take insulin. Diabetes, right? So diabetics get peripheral vascular disease, and so this is like, if I had to bet my paycheck, which isn't much, this is probably a diabetic. Diabetics get all sorts of gangrene on their feet. Okay. Now you're like, what the heck? What's this? It's called Fournier's gangrene. It's a little different, but this is again gangrene of the perineum, and so this is particularly bad and lethal. And, this is dead tissue. You can tell they've already started debriding it too. So, anyways, this can result in sepsis. And so, as you can imagine, as this tissue is dead and dying, it allows bacteria to grow on it. And as this bacteria grows, if that gets sucked up into the bloodstream, you have bacteremia, i.e., bacteria in the blood. And so you end up with a systemic infection, and so you can lead to sepsis, and sepsis is remarkably fatal. It is a form of distributive shock. Okay? Now, you do have to worry about a bacteria called tetanus. The technical name of this is called Clostridium tetani. And so, what happens with tetanus is it causes all your muscle. Okay, the bacteria releases this potent toxin, and what this toxin does is it causes all your muscles to contract, all of them. And so, you see this classic example of an arched back, and so, excuse me, it's severe hyperextension of the muscles, and so you can see that, and you can also see this example called rhesus sardonicus, where they'll have like this little evil-looking look on their face because all their muscles are contracted. And so, tetani, this tends to be a common piece of dirty wounds, specifically like metal. So if someone steps on like a rusty nail or something like that, you have to worry about Clostridium tetani. And so there is a vaccine for this that you've probably had, hopefully. And so the thing is, if someone's been exposed to this, it depends on the person and the exposure. They may have to get another tetanus shot. And so tetanus is what we do is, like, say you stepped on a nail now, and you're in the ER 30 minutes from now, we'll give you a shot of the vaccine to make sure that you're going to be covered before the virus, or the bacteria can grow. And so this is something to be aware of. Tetanus is a real thing. We do give a lot of tetanus shots in the ER for this reason, because this is fatal, right? Like, when this happens, you have to provide the patient. So every muscle in the body gets contracted, and what muscles help us breathe, right? The diaphragm and the intercostals. So when those become tight and they stop working, the patient goes into respiratory failure. So this can kill you. Okay. Now, necrotizing fasciitis, you do see this in Texas. This does happen, and me and the surgeon are convinced. The patient that I told you about earlier in this video, we think it looked like this. It really did. And so we're thinking it might have been caused by this. We don't know for sure, or it was a different one, Clostridium perfringens. So we don't really know, but like I say, it died too quick. But the guy was really sick anyways. But what I'm saying is this does happen. Don't think like, oh, well, this is just in the book. No, this actually happens. It's rare, but it does happen. And so what happens in necrotizing fasciitis is you get bacteria up underneath the fascia, and this becomes inflamed and infected. And so it creates compartment syndrome. And so you'll get, again, pain that is out of proportion with movement. So basically, if this was on the patient's arm and you passively move the arm, it's going to be extremely painful for the patient. You would suspect compartment syndrome. And so the treatment for this is usually you open it up and debris it. So you open it up and you remove all the infected material, and you might even do what's called a fasciotomy, which is where you go between the different layers of the muscle and you open them up. You cut the layers of fascia. That way there's room for it to grow and expand. That way it's not in this tight compartment. So you avoid compartment syndrome. And so that's the treatment for this. So a physician should always evaluate certain wounds. I'd say all wounds, right? Assessing closed injuries is more difficult than assessing open injuries. Again, a closed wound you can't see, right? So they can deceive you, especially a fresh one. So a fresh closed wound may look pretty good right now, and then 2 hours from now, it's this huge, nasty hematoma. and the patient's lost a lot of blood, and so you got to worry about issues like that. So when in doubt, transport them to the ER always. We're in the business of taking people to the hospital. So scene size up, address some scene hazards, and take standard precautions. Maintain a high index of suspicion for internal injuries when a significant mechanism of injury is present. And this is why we use our index of suspicion, where we're like, oh wow, they were hit in the abdomen with a baseball bat. That is a high index of suspicion that they're going to have internal injury. And so you have to worry about those things. Okay. So we do the primary survey. You're going to rapidly determine whether life threats are present using, the X, A, B, C, D, E. So X is for exsanguination. That means bleeding out. Okay. Airway, breathing, circulation, disability, and I think E is environment. And control substantial bleeding. Okay. And so we can control most bleeding through direct pressure, or if it's on the extremities, you can use a tourniquet. If it's in torso-junctional wounds, you can use direct pressure and or wound packing. And so keep that in mind. We have all those tools in our toolbox. Before manual immobilization, if spinal injury is suspected, check for responsiveness using the APHU scale and assess breathing and circulatory status. Gather information to determine the MOI. So this is where, you may have to look at scaffolding that's 30 foot up in the air and realize like, oh, well, they could have fallen, if the patient's unconscious and alone, they could have fallen from 30 feet in the air. So you have to assume that, right? And so this, again, that's where you play detective. Well, it's an 18-foot ladder. Well, you need to think like, oh, if they're at the top, they fell 18 feet at least. So just keep that in mind. Now, we use the OPQRST mnemonic to provide background and isolate injury, extremity injury. So onset, when did this happen? Provocation, what makes it better or worse? Quality of pain, is it dull, fire, pressure, stabbing, aching pain? Does it radiate? So is it radiating from their arm into their shoulder? What is the severity? So we ask the patient, pick a number between 0 and 10, 0 being no pain, 10 being the worst pain ever. What would you rate your pain right now? Okay. And T, time, when did this begin? Okay. Higher priority should be given to patients taking warfarin and other anticoagulants. This is a good point. So there are medications on the market. Warfarin's a common one, heparin, Lovenox, Apaxaban, Xarelto, Eliquis. I mean, the list goes on and on of these true blood thinning agents. And so the blood will be thinned to usually prevent blood clots, like in the heart or in the vessels. And so you have to worry that they will bleed and bleed and bleed and bleed and bleed because we have given the medicine that have caused their blood to be thin to where it's not going to clot like my blood would. And so you have to worry about that. So these patients are high priority. Even if it's fairly low index of suspicion, what does that mean? A patient, okay, 65-year-old lady, ground level fall, no other medication, no medical history. Kind of a big deal. Take her to the hospital. We'll figure it out. Same scenario. 65-year-old lady, ground level fall. She takes warfarin. Big deal. So it is truly a big deal now because you have to worry, did she hit her head? Is she bleeding inside her head on her brain? So it's a lot more workup. It's a lot more aggressive care. It's a higher priority patient. That's what they're saying here. Okay. Secondary assessment, remember this can be done en route to the hospital or not done at all. Reveal injuries or medical conditions that are missed during the primary survey. Reassess vital signs. Soft tissue injuries can cause shock. You should be aware that, like, for example, if you were to take a baseball bat to the mid-femur, you could lose a liter or more of blood in your thigh space. So it's a lot of blood that could lead to shock. And so just be aware that you can lose a lot of blood from internal injuries, even internal soft tissue injuries, okay? And we would use our monitoring devices, okay? So we reassess these patients frequently en route to the hospital or anytime you just keep reassessing them. 5 minutes for critical, every 5 minutes for critical patients, 15 minutes for stable and non-critical patients. And so you're going to reassess their vital signs, okay? Reassess their airway, breathing, circulation. This can change. As patients continue to bleed and die, they get worse and worse. So don't get caught sleeping right in your report and the patient's dying on the stretcher in front of you and you're not catching it. So reassess your patients. Now, moving to closed injuries. Extensive injuries could result in hypovolemic shock and be life-threatening. I described this in the femur. Again, if someone takes a baseball bat to the femur and you bust an artery, you could hold at least a liter of blood in the femur. It's a lot of blood, okay? Assess and manage all threats to the airway, breathing, and circulation. Treat by using, this is the Rice's mnemonic, rest, ice, compress, elevate, and splint, okay? This is a general musculoskeletal injury treatment. This is how we treat injuries of musculoskeletal injury is rest, ice, compress, elevate, and splint. Okay? Extremities are painful, swollen, or deformed should be splinted. And so keep in mind that I think that EMTs and paramedics do a really good job of like an arm that looks like a question mark. You're like, oh, we got to splint that. But an arm that is straight, but it is still painful, we should still splint that. Okay, and we'll talk about splinting orthopedic injuries, but just keep that in mind. It doesn't have to be deformed to get a splint. We still put splints even if it's just pain. Okay. For signs of shock, place the patient supine. If you're qualified, you could initiate IV therapy, give high flow oxygen, keep the patient warm, and promptly transport. Remember, on scene, trauma time on scene for the on-scene time for trauma patients should be less than 10 minutes. Now, we're just really, for these injuries, you're not going to be suturing them up and shooting an X-ray and closing their open fractures in the field. And so it's really, we're just trying to minimize complications like blood loss and infection and further injury. That's the idea, okay? So take your standard precautions, address life threats, bleedings, and assess wound severity, right? I don't have a lot to add to these, that's why I'm kind of reading to you. Control the bleeding. Remember, direct pressure is very effective for all bleeding. So when we don't have a tourniquet, we just become really good at direct pressure, okay? Pressure dressings and or splints are effective, like air splints especially, and tourniquets. Now, there is a scenario which we'll talk about a little bit more at the end of in burns and especially in the last few chapters of this book, like in weapons of mass destruction, terrorism. But there's chemical burns that can occur. And so I think we do really good to recognize like extreme heat or extreme cold, like dry ice, or can burn you. But there are materials like lye, spelled, that can burn you badly. And this is caustic to the skin. There's obviously, you tend to see these in industrial settings, like in a factory or in a farm or something to that effect. But it could happen with household materials as well, theoretically. And so the idea is this is how you treat this. Watch for this on an upcoming test near you. You would want to first decontaminate the area and flush it. So you would flush it with water or saline, and you would, with copious irrigation, you would irrigate and flush the wound. You would try to get it off, right? After the wound is irrigated with copious amounts of water and fluid, and they're decontaminated, you would apply a dressing and wrap with a bandage, okay? So you've probably never seen a real burn in real life, but this is really what burns kind of look like. So this is a chemical burn. We happen to know that because I'm telling you that, but yeah, I could also tell you like, oh, this guy poured gasoline on himself and lit himself on fire. It would look similar, okay? It's a burn. So he has damaged the tissues of the skin. In fact, these look like second or even third degree burns. They look pretty severe. So dressing and bandage. Dressing directly covers a wound and controls bleeding. The bandage keeps the dressing in place. So that's something I want to talk about. The dressing is what sits on the wound, and then when we wrap it, that's the bandage itself. Okay? Again, this is to minimize risk to the patient, control bleeding, protect the wound, and prevent contamination and infection. So we use a lot of 4x4. So it's I meant to grab them. They're back there. But it's like a little 4x4 dressing. They're like the size of a sticky note, roughly, maybe a little bigger. And so they're little dressings that you've seen this. And so that I'll just take a big chunk of these and throw them on the patient, and then wrap it up with some gauze. Okay, and so you have adhesive type dressings. We don't use these very often. Where you'd use an actual, like a true occlusive or adhesive dressing is like injuries to the neck, where adhesive means you want to like seal it up. Yeah, I think what they're describing here is small adhesive type dressing is like what we would consider a Band-Aid. But when I'm talking about like a true adhesive or what's called an occlusive dressing, we use these lots on the neck or like on a chest seal or something like that. We'll show you what those look like in class. You'll get to play with all these. And then soft self-adherent roller dressings, that's what's called like a roller gauze, okay? Oh, an occlusive dressing is what I was telling you. So you use these like on chest seals and maybe on the neck. And so they have a little bit of utility there. They're not used very often, but they do have utility. Okay, so again, this is just showing you pictures, and I'm so mad at myself for not grabbing the bandages that are behind me, but I'm not getting up to do it. So anyways, we'll show you what these are in class. They're kind of self-explanatory what they are, but we'll cover these in Stop the Bleed class, and we'll be using these in scenarios and stuff like that throughout the course to where you'll get pretty familiar with them and comfortable. Okay. Now, here's the complications or the risk of improperly applying a dressing. The first one is that you don't do it tight enough or you don't recognize it's life-threatening bleeding. and it'll continue to bleed. And any blood loss is unacceptable. So you want to stop the bleeding. Okay, one. Two is you could have additional tissue damage, and or you could even apply it too tight. This is rare, where you could have further tissue damage or loss of a limb. And so just keep that in mind. It's very basic to cover a wound and stop the bleeding and cover a wound. It sounds pretty basic, but there is a risk to this if you don't do it properly. Again, we will cover this in class, and you'll be very proficient in this. In fact, I deem you an expert when we are done with you in class on this. Okay. So here's how you specifically treat these. Again, these are going to be very intuitive. It's like what you would think, right? But if you have an avulsion, remember avulsion is the skin flap, okay? What you do is you're going to place that avulsed tissue back into its original position. So if the skin's flayed back, you're going to push it back to where it once was and wrap it, okay? And you'd wrap it in separate tissue and sterile gauze and take it to the, and if it's been completely avulsed, so let's just say like a big chunk of flesh has been removed, you're going to take that and you would wrap it in sterile gauze and still take that to the ER. And you're like, huh? Well, they can reattach that sometimes, so take it with you. I mean, as long as it's probably like bigger than a fingernail, take it with you. If it's smaller than that, you're wasting your time. But if it's bigger than a fingernail, take it to the hospital if you can find it, okay? Now, an amputation involves a large area of muscle mass, sometimes even bone. Apply a tourniquet and treat the patient for hypovolemic shock. I will say on an amputation, if possible, you should try to take the tissue with you to the ER. Again, you would wrap that into sterile gauze, moisten sterile gauze, and take it with you to the hospital. Now, again, if it's bits and pieces of fingers smaller than the size of a fingernail, you could try to take it, but they're not going to be able to do anything with it. And so just keep that in mind. I had a guy once who took like a mortar shell for a firework. Instead of placing it on the ground, he placed a base pad in his hand. Well, it blew his hand off. This is at Hillbilly Haven, surprise. And so these poor souls, the bystanders were picking up like literal bits and pieces, like the size, like just crumbs of his tissue out of the sand at the Brazos River, and put it in a bag, filled his hand, and gave it to us. We took it to the hospital, but they flew it to the hospital with them. But I'm like, they're not gonna be able to use that. But if bystanders gathered it, just thank them for their help. Send it with the patient. Someone else can make that decision. But don't delay on scene times to gather the tissue. Okay. Now, with partial amputations, you'll have to stabilize it. So this is where you'll want to use like a splint to keep this from further flopping and fully amputating itself. And so these are actually fairly common. Partial amputation. I've ran by far more partial amputations than full amputations. And so one thing I'll say about these is they bleed a lot because you have sheared the vessels, you have not sliced the vessels. And so you can imagine if we're looking at a water hose and I just slice it, saying this is an artery, it'll coil up on itself really effectively and usually stop bleeding. So complete amputations tend to not bleed a whole lot. Now, opposite scenario, if you take this tissue and you just avulsed it, it's really hard for it to coil up on itself, so these bleed a lot. And so just keep that in mind. These are the ones where they'll bleed a lot. Bites, promptly control all the bleeding, apply a dry sterile dressing, immobilize the area with a splint or bandage. Remember, even though it's not broken per se, sometimes you still will splint these, okay? Provide the patient to the ED for surgical cleansing of the wound and antibiotic therapy. That is very important. That is not just us being dramatic. That really does need to happen. Now, penetrating wounds, this is important. Entrance wounds and exit wounds are difficult to distinguish. Now, in the terms of bullets, the entrance wound tends to be smaller and the exit wound will tend to be larger. So that is a general principle you should know. If available, this could be very difficult if they're shot multiple times or stabbed multiple times. You could count the number of wounds. Now, this example is an entrance wound. I can guarantee you that is an entrance wound. Okay. Now, this is probably the exit wound, or it was very close contact with the end of a barrel. And so keep that in mind. Exit wounds are usually larger. Okay. Now, let me add something a little extra. This could theoretically, depending on the bullet, like if it's a fast-moving rifle and it didn't hit any bones, this could also be an exit wound. Okay, so there's variables to how fast the bullet's moving, what size the bullet is, how far they were from the person that was shooting them. So just keep all these things in mind. You're not expected to be a forensics expert, but these are general rules. Okay, what is it called? Coming to a test near you. When a bullet enters a cavity and it expands and it slams the tissue back together, what is that called? It's a phenomenon. I gave away the word called cavitation. It's on your exam. Now, Abdominal wounds, if internal organs are protruding through an open wound, do not touch or remove the exposed organs. What does that mean? Remember the picture earlier where the guy had the loops of bowel sticking out of his stomach or his abdomen? We don't push that back in. Leave it alone. You would cover it with a moist, emphasis on moist, sterile dressing, and you would secure it with an occlusive dressing. So what does that mean? You're going to take your gauze, you're going to pour some saline in there and get it wet, moist. You're going to cover that loop of bowel. And then you're going to take an occlusive dressing like a chest seal or a trauma pad, and you're going to tape it on all sides. Why is that? You want to keep the tissue warm, wet, and clean. And so we're achieving all of that. Now, it is very important to keep bowels moist. I recently did this in surgery. We had a very long case where we were working on this lady's colon, and we had to keep pouring irrigation in there because it was opened up to the air. And not only that, we were suctioning. And so we're drying out this tissue. So you have to keep bowels moist or else they will get dry and brittle. Not brittle, but they get dry and it makes them unhealthy. Okay? Bowels like to be moist. Now, an impelled object, something I want to know, if the object is very long, cut off the exposed portion, securing it to minimize motion. So if you have a 10-foot piece of pipe sticking through someone, you cannot take that to the ER with you. So what you want to do is stabilize it, and then someone very skilled, very carefully will cut it to make it manageable. 1. 2, coming to a test question near you. When do we remove penetrating objects? Simple line. When do you remove penetrating objects? Never. The only exception to that rule, is if it interferes with CPR. So what does that mean? If you have a pipe sticking or like a knife lodged in someone's spine, you can't lay them flat to do CPR. So that would be like the only acceptable time to remove an impelled object, a penetrating object. I don't care if it's in their eyes, I don't care if it's in their skin, I don't care if it's in their bladder, I don't care if it's, where it's at. We don't remove it unless it interferes with CPR. Test question, 65-year-old male has a knife impelled into his lower right abdominal quadrant. He goes into cardiac arrest. What do? You start CPR. Do not remove it because it's not interfering with your CPR. Now, same scenario, 65-year-old male has an 8-inch Kincha knife impelled into his chest. He suddenly goes into cardiac arrest. What do? If it interferes with CPR, like if they say it's peristernal, meaning next to the sternum, you remove the knife. It's the only time you can do it, okay? Very important. Now, with neck wounds, again, you can't apply a tourniquet, or at least you shouldn't, and you should apply, and direct pressure can be really difficult because if you push too hard, you could occlude the vessels and or occlude the trachea. So what you do is you can apply a little bit of manual pressure, but you want to apply an occlusive dressing like what they're doing here to cover it. That's really all you can do, okay? Now, that's it for this section. One thing I want to stop here, I want to add something that's important. We'll talk about this more, and I'll say this a lot. This can be scary. You will see this with the look on someone's eyes the first time they see this, when you see someone bleeding, or even if it's not a lot of blood. But remember, there's a few important concepts that I want you to remember. You're trained, you're there to help, stop the bleeding, and all bleeding stops eventually, right? They will eventually stop bleeding and or die. And so it's not your emergency. You did not do this. You are there to help. And panicking and getting caught in emotion will usually, almost always, just make it worse. And the reason I'm telling you this is you think like, no, I'm tough. I play Call of Duty. I'm good. I've seen this. No. When you see someone that has a small 1 centimeter laceration to their forehead, but their whole face is covered in blood in real life, and you can smell the blood, and it's like, wow, this is scary. It's very scary when you disfigure someone. So just be aware of that. Mentally prepare yourself for this. Because you will see this in your career for sure when you see someone bloody. Okay, now with that, we'll go to the next chapter, and I appreciate your time.